Hello, everyone. Welcome back to the Shoulders Up podcast, where we break down complex headaches and dizziness. So, today we're actually going to be doing something a little bit different. Today, what I want to talk about is this big, scary topic called Medicare. So, we're going to get into Medicare policy and how it applies to physical therapists in the nation, whether you're an insurance based provider or cash based provider. This should all be good information. So naturally, this isn't really a patient-facing episode, but I think Medicare definitely raises a lot of questions for a lot of therapists, especially for people who may be like me, who are primarily cash pay therapists, but are interested in working with Medicare patients. So there are a lot of misconceptions around Medicare, what you can do, what you can't do in regards to how you charge them, how you see them, what services are covered, what services are uncovered. My goal today is simply to challenge some of the notions that you may have about these subjects. So obviously Medicare is a huge topic and it can't just be covered in a single podcast episode, but what I'm really hoping to do is to challenge people's assumptions about how Medicare might work. So for context, I am a primarily cash-based physical therapist. So I'm out of network with all private insurance, but I will say that I am a participating provider with Medicare. Some cash pay providers may think that this is an odd decision, and we're going to go over why I did this. So quick recap on the Medicare laws in this country, especially relating to the mandatory claim submission and the opt-out rules. So let's start with the basics. So when it comes to Medicare, healthcare practitioners have a couple options. One option is that they can either be enrolled in Medicare or they can be unenrolled in Medicare. So when you're enrolled in Medicare, you can either be a participating provider or a non-participating provider. Now, don't get thrown off by this word non-participating. If you are a non-participating provider, you are still enrolled in Medicare. And when it says non-participating, it just means you're not participating with their typical fee schedule. To make matters more confusing, non-participating providers have a separate fee schedule. But I digress. And then the other option is to opt out. So if you are an opt-out provider, what that means is you've completely opted out of Medicare, and what you can do is you're totally within your legal right to charge your patient cash. But here's the caveat. Physical therapists are not opt-out providers. So as physical therapists, we cannot opt out, and therefore our only option is to be either enrolled with Medicare or to be not involved with Medicare at all. So I think this is where people run into some misconceptions. They think, okay, well, if I'm unenrolled in Medicare, and even though I've never gone through a formal opt-out process, since I have no relationship with Medicare at all, I should be able to charge my patients cash. And I've heard through the grapevine that there are a number of practitioners now who are operating under this model. They have certain intake forms that explain this to their patients, and they're using that to justify charging cash to their Medicare patients. So I hate giving unsolicited advice, so I pretty much never say anything when this comes up. For better or worse, since this is my platform, I'm going to publicly say it here that I do not think this is a legally defensible position. Now, I'm not a lawyer. I'm just a physical therapist who had too much time and decided to read all these policy documents. Lord help me. But I'm going to try to stay away from making conclusions on my own, but I'm just going to read verbatim some interesting passages from the Medicare policy manuals and Medicare documentation out there. And using that, I'd like to really challenge what people think is a covered versus uncovered service. So going back to the opt-out rule. So right now what I'm looking at is Medicare Chapter 15, Section 40. So CMS Chapter 15, Section 40 says, normally physicians and practitioners are required to submit claims on behalf of beneficiaries for all items and services they provide, for which Medicare payment may be made under Part B. Also, they are not allowed to charge beneficiaries in excess of the limits on charges that apply to the item or service being furnished, i.e. no balance billing. However, a physician or practitioner, as defined in Section 40.4, may opt out of Medicare. A physician or a practitioner who opts out is not required to submit claims on behalf of beneficiaries and is also excluded from limits on charges for Medicare covered services. Only physicians and practitioners that are listed in 40.4 may opt out. So if you scroll further down to section 40.4, what you're going to see is that physical therapists are not listed as an opt-out provider. And there are more detailed documents, but essentially what this passage has been implying is that if you are not an opt-out provider and you see a Medicare patient for a covered service, you are legally required to submit a claim on their behalf. And this is known as the mandatory claim submission. So even if you have no relationship with Medicare and you see a Medicare patient, a Medicare beneficiary, and say they want to go through you with cash, for a covered service, you're still required to submit the claim on their behalf, and you shouldn't be collecting payment from the patient. It's a little bit different with non-participating providers, but that's getting a little bit more into the weeds. So I'm going to read the next section of this passage, and I think this is where some people get confused. So here it is. The only situation in which non-opt-out physicians or practitioners or other suppliers are not required to submit claims to Medicare for covered services is where a beneficiary or the beneficiary's legal representative refuses of his or her own free will to authorize the submission of a bill to Medicare. However, the limits on what the physician, practitioner, or other supplier may collect from the beneficiary continue to apply to charges for the covered service, notwithstanding the absence of a claim to Medicare. So what is this saying? So it's saying, okay, you do have an option of charging the patient cash if both of you are in agreement that you don't want to submit a claim to Medicare. But even if you were to do that and you had this, paperwork documented saying that, you're still going to be limited to the Medicare allowed amounts. So you'd still have to have a good idea of the Medicare fee schedule. You'd have to look it up, and you'd only be able to charge that amount for the patient in this situation. So this leads a lot of physical therapists in a hard place, because we all know Medicare reimbursements have decreased by over 30% over the past decade. And I know there was like a 1.85% increase last year. I mean, it's a drop in the bucket, right? Especially when you take into account inflation. So I don't think it's an exaggeration to say that Medicare underpays the physical therapists in this country. So what are physical therapists to do, right? More and more people are leaving the insurance realm because it's practically impossible to work with. It's practically impossible to work under those conditions anymore. But when it comes to our seniors, this leaves a lot of cash pay physical therapists in between a rock and a hard place. Do they just not see seniors at all? Don't see anyone over 65? Or do they try to do this hybrid practice where they enroll with Medicare and then also have cash pay for anyone under 65? So that's the standard dilemma that we have for a lot of people right now. And it's definitely something that I've struggled with. But this is where I'm going to differ from what most people think. And I am going to tell you that there is opportunity in Medicare. There's a lot of opportunity in Medicare. And what you'll commonly hear, and you might have noticed my language is a little different than other people, what you'll commonly hear is you cannot charge a senior cash for a physical therapy service. This is partially true. It's not the whole truth. You cannot charge a Medicare beneficiary for a covered service. So, believe it or not, there is such a thing as an uncovered physical therapy service. And in the event that you have an uncovered physical therapy service, you have the right to charge that patient or beneficiary cash at your own set fee schedule. So I'll give you a really obvious example. So Medicare Advantage, right? For those of you who don't know, Medicare Advantage is basically Medicare that's managed by a private health insurance company versus original Medicare. Medicare Advantage, there are HMO Medicare Advantage plans. So Kaiser Medicare Advantage is an example. And because it's an HMO, any services that are provided out of the HMO network are not covered. So as a cash pay therapist, you can see these Medicare Advantage HMO patients at your set cash rates. Because your services are not covered, it is considered an uncovered service, even though it is a physical therapy service. So you can charge them cash. You just have to provide them a good faith estimate, which we should be doing anyway. So that's a really clear example. That's an example that's really easy for us to wrap our head around, right? So what about original Medicare? What about Medicare Advantage PPO? Again, people say, well, physical therapists can't charge them cash for physical therapy service. And that's true if it's a covered service. And like I said, there is such a thing as an uncovered physical therapy service. So I'm not a lawyer, like I mentioned before. I'm just somebody who decided to take Anthony Maritato's Zero to Paid course from the GOAT himself. I highly recommend it if you're interested in Medicare at all. And on the side, I also read all these Medicare policy manuals because I really wanted to make sure I knew what I was doing. But I don't want to draw any conclusions for people. I think the best way to kind of flip this switch, change the way we think about this, is actually just to read a lot of sections verbatim. Now, obviously, I'm not going to read the entire policy manual to you. It's already pretty dry, but I've pulled some highlights from different sections, and these sections are all going to give you examples of services that actually aren't covered, that I would argue that most physical therapists would think is a covered service and wouldn't be comfortable charging that patient cash for what is very obviously not a covered service. And when you do this, what you're going to start realizing too is that a lot of therapists, private practices who operate within the insurance model, billing Medicare for services that actually aren't covered. So what are the criteria? What are the criteria for a covered service? And generally speaking, you can think of three. One, it has to be considered skilled. It has to be a skilled physical therapy service. And then the second one is it needs to meet criteria of medical necessity. And then it also needs to be reasonable. This is where some people get tripped up. You have to understand when Medicare talks about skilled therapy service, medical necessity, services being reasonable, they aren't using standard definitions of these terms. They have their own definition of what is considered a skilled service, what is considered medically necessary, and what is considered reasonable. The way they define these terms aren't the way that normal people would typically define these terms. And that's a whole discussion in and of itself. So I think I'm just going to dive right in, and I'm going to read a couple sections verbatim because I don't want to draw any conclusions for people. I'm going to read some sections verbatim. You're going to see how a lot of services that we typically think are covered actually aren't covered at all. So let's start here. So this is chapter 15, section 2, part 8. So it says, a service is not considered a skilled therapy service merely because it is furnished by a therapist or by a therapist/therapy assistant under the direct or general supervision as applicable of a therapist. So already we're starting to see how some of these outpatient private practice models, it's starting to break down a little bit because we know a lot of these insurance mills, they're highly, highly dependent on their aides and they're billing for that time. But Medicare is saying here point blank that that is not a covered service and really you should not be billing Medicare for that. So moving on, if a service can be self-administered or safely and effectively furnished by an unskilled person without the direct or general supervision as applicable of a therapist, the service cannot be regarded as a skilled therapy service even though a therapist actually furnishes the service. So that's a bit of a word salad right there. But what that is essentially saying is if there's an exercise that maybe you could have told an aide to do with the patient, right? You had the aide supervise the patient for that. That's not a covered service, right? Because we already established that that's not a skilled clinician. So that wouldn't be a covered service. But say you are the one who is supervising the patient, but you know, or the exercise meets certain criteria that you would feel comfortable handing it off to an aide, right? In that event, Medicare is very clear that that is not a covered service, even though the skilled person, the physical therapist, is actually furnishing the service. So already we're starting to see how some of our assumptions about covered versus uncovered services are starting to break down. Okay. So we're going to move on to another example. This example is talking about maintenance therapy. And I should have said this earlier, but I'll say it now. So these sections of Medicare, they apply to PT, OT, and speech. So this example is talking about speech therapy. So I'm going to go ahead and read it. So it says, a patient with multiple sclerosis needs a maintenance program to slow or prevent deterioration in communication ability caused by the medical condition. Therapy services from a qualified speech-language pathologist may be covered to establish a maintenance program, even though the patient's current medical condition does not yet justify the need for individual skilled therapy sessions. Evaluation, establishment of the program, and training the family or support personnel may require the skills of a therapist and would be covered. Note, in this example, the skills of a therapist are not required to actually carry out the maintenance program services and as a result are not covered. So what is this passage saying? When it comes to legal language and policy documents, they use a lot of run-on sentences. It's easy to lose track of what they're trying to tell you. But in this case, they're basically talking about there's a patient with multiple sclerosis and they're having certain deficits and they need an exercise program to prevent deterioration. So the therapist's job is to do an evaluation and then establish a maintenance program. Now, once the program is established, like a robust home exercise program, we all know patients would like the therapist to return, to administer it with them, to do it with them, right? Provide them support. This is really what good care looks like, right? But in this example, Medicare is saying because the program has been established and the patient could probably do it on their own or with the help of a caregiver or a family, you going back and doing the program with them is not a covered service. Even though you, the therapist, are present and you are the one administering the service, that is no longer a covered service. So when you hear people say, well, Medicare covers maintenance, a lot of them take it to mean that you can see Medicare patients indefinitely if they have a chronic condition. And this passage is making it very clear that you can't do that. Okay, so those are from the CMS policy manual. And then so there are different policy manuals and documents that apply, at the regional, the local level, and then a lot of Medicare Advantage plans also have their own policy bulletins. But generally speaking, there's a lot of overlap, and they can all be considered good source material for determining your Medicare policies with your practice. So we're going to be looking at the CGS local coverage determination. So CGS is a Medicare administrative contractor in the region, in the country, and they have released more specific rules about what may be considered a covered versus an uncovered physical therapy service. So this is CGS Local Coverage Determination Document L34049. Okay, so let's actually start with this passage here where it says what practitioners cannot be considered skilled therapists. So there's some obvious examples, and then there's some less obvious examples where we know a lot of clinics are probably billing to Medicare anyway. So it is saying students, aides, athletic trainers, exercise physiologists, massage therapists, recreation therapists, kinesiotherapists, low vision specialists, lymphedema specialists, Pilates instructors, rehabilitation technicians, and life skill trainers are not considered qualified therapy. So there are some obvious examples here, like a Pilates instructor, massage therapist. You cannot bill for these services that are being provided by them. But it also mentions aides. It mentions students. It mentions athletic trainers, low vision specialists, lymphedema specialists. These are all practitioners that I think a lot of clinics would comfortably bill Medicare for these services. But here, Medicare is saying point blank, again, these are not covered services, and therefore these services should be charged cash. And because it's an uncovered service, you're also not limited to the Medicare allowed amounts. This next section is one that I find to be very, very interesting. And this is talking about, okay, so we've talked a little bit about how an independent home exercise program is established and well established. Then after that, care is not considered medically necessary, doesn't meet the criteria for medical necessity by Medicare guidelines. So when you have someone with a lot of cognitive deficits, how does that come into play? Because maybe some people with a lot of cognitive deficits, they can't administer the home exercise program by themselves independently. And so here's another passage from the local coverage determination, and it says, if a patient's limited ability to comprehend instructions, follow directions, or remember skills that are necessary to achieve an increase in function is so severe as to make functional improvement very unlikely, rehabilitative therapy is not required and therefore is not covered. So what's it saying here? So what that is saying is that if you have a patient with severe cognitive abilities and they aren't able to learn how to do a home exercise program, right, then you seeing that patient is not considered medically necessary or reasonable and is therefore considered an uncovered service. Training a family member, training a caregiver, that could be considered covered, if you use it to establish a program. But if the family or the caregiver wants you going back and seeing this patient all the time, that's no longer considered a covered service because of these guidelines. So moving on, let's talk about exercise. So I'd say that a lot of therapists, we repeat exercises between sessions, right? And a lot of outpatient clinics, they bill for this time. They bill it as a separate service. But if you look at what Medicare says, that is not actually something you can do. So this is the next passage I'd like to read. So it says, as part of the initial therapy program following total knee arthroplasty, a patient may start a session on the exercise bike to begin gentle range of motion activity. Initially, the patient requires skilled progression in the program from pedal rocks building to full revolutions, perhaps assessing and varying the seat height and resistance along the way. Once the patient is able to safely exercise on the bike, no longer requiring frequent assessment and progression, even if setup is required, the bike now becomes an independent program, is no longer covered by Medicare. So this becomes a lot more nuanced when we start looking at other therapeutic exercises. The example of the bike may not apply to all situations, but I think we can all agree that this isn't something people tend to assume People tend to assume that as long as the exercise is being done in a physical therapy setting with a physical therapy practitioner, it should be a covered service and should be billed to Medicare. But we're seeing here in Medicare state point blank that that is not a covered service. Okay, so moving on, we're still in the CGS local coverage determination, and I'll say that this document is littered with examples of what is not a covered service that I would say most physical therapists consider to be covered. So when you get to the bottom, this is where it gets particularly, I would say, juicy. This says miscellaneous services. The following are non-covered as skilled therapy services. This is not an all-inclusive list. As if this list wasn't already long enough with the amount of things that aren't covered. But apparently it's not all-inclusive. So I'll start with some obvious examples. Massage chairs or roller beds, not covered. Low-level laser therapy treatment, not covered. Dry hydrotherapy massage, not covered. Electromagnetic therapy, except as indicated for chronic wounds, not covered. Okay. Now, let's go on to some of the other ones that they're also saying is not covered. I'm a vestibular therapist. Medicare is saying here point blank. It says vestibular ocular reflex training, not covered. Interactive metronome therapy, not covered. For those in ortho, CPM, I know most of you aren't using it anyway, but just know CPM is not covered. For some of you who are doing cranial sacral therapy, it says here, cranial sacral therapy, also not covered. Those of you in stroke rehab, constraint-induced movement therapy, not covered. OTs, driving assessments, not covered. OTs, work hardening programs, not covered. And then for my pelvic floor people, it is saying pelvic floor dysfunction, except for incontinence, is not covered. And then it lists several pelvic floor conditions here that aren't covered. Pelvic floor congestion, it says pelvic floor pain, not of spinal origin, prostatitis, and then a bunch of these other conditions that I know absolutely nothing about. And some of these other conditions where I start saying I'm probably going to giggle and blush. So these are services that a lot of cash pay PT practitioners provide. They provide these services, right? And they have a right to charge cash. But because of the Medicare opt-out rules, the Medicare mandatory claim submissions, they don't feel comfortable making these discernments between covered and uncovered services. So their decision is to simply not see Medicare beneficiaries. And I think that's the biggest reason why, personally, that I decided to become a Medicare participating provider. It's because I thought people over 65, they're the people that need our help the most. So it made sense that I would want to work with them. But given the conditions of Medicare, how they keep cutting reimbursements and they're increasing the amount of audits, right? We have to become more strict on the rules because otherwise they're just going to eat us alive. And reading these documents, I think a lot of people who are listening, you may start to hear some opportunities for cash pay services. So far, these documents have all been pertaining only to original Medicare, traditional Medicare. So now let's talk about Medicare Advantage plans. So we already discussed the example of Medicare Advantage HMO plans, how if you're an out-of-network provider, then it's not covered and you are totally able to just see them for cash at your set cash rates. But what about PPO plans? PPO plans, they have their own policy bulletins. And here's the thing. I've read you some of the original Medicare. I haven't even read you all of it, but I've read you some of the original Medicare policy manuals, and you're starting to see how a lot of things aren't covered. Medicare Advantage plans are even more restrictive than original Medicare. And the way they loop people into Medicare Advantage plans is that Medicare Advantage, the private insurance companies, pays off most of your Medicare Part B premium. So effectively what that looks like is that your premium is really low every month, some as low as $15, $20 a month to be on a Medicare Advantage plan. And the reason these private Medicare Advantage plans that they can afford to do this is because they develop more stringent laws, and what they do is they increase the rate of denials. And that's why they're able to charge less, because they're reimbursing less. So what I've got pulled up here in front of me is Aetna Medicare Advantage PPO policy bulletin. I'll be sure to link all of these different policy documents in the show notes. So I'm just going to read some of these now. And I'm telling you, once you guys look into this policy bulletin, you're going to see just how restrictive it is. I'm just going to keep doing what I'm doing. I'm just going to keep reading these things verbatim, and everyone can draw their own conclusions. So here it says, physical therapy in asymptomatic persons or in persons without an identifiable clinical condition is considered not medically necessary. Physical therapy in persons whose condition is neither regressing nor improving is considered not medically necessary. Once therapeutic benefit has been achieved or a home exercise program could be used for further gains, continuing supervised physical therapy is not considered medically necessary. Now, that one is a really big one. So it's saying once an HEP has been established and it can be used for further gains, then any continued physical therapy is not considered medically necessary. This little section essentially gives, auditors the green light to pretty much deny a lot. Yeah, it could deny a lot because we're establishing home exercise programs from the very beginning. And while, we're still building on it from insurance's view, a lot of times that once you build like a basic couple exercises, that should be sufficient for them to continue growing. And then let's get a little more specific here. So this one is saying, there are no reliable data demonstrating that the following methods of physical therapy are superior to standard methods of physical therapy. Thus, it is not medically necessary to go out of network for these specific methods of physical therapy when standard methods of physical therapy are available in network. And it states, McKenzie method of mechanical diagnosis and therapy, Downey method of physical therapy, muscle activation techniques, postural restoration form of physical therapy. So whether you agree with these methodologies or not, I think we can all agree that these are very popular treatment frameworks that a lot of therapists are out there using. And NPPO is essentially saying that these services, these techniques are not covered. I'm going to keep going. The following physical therapy interventions are considered experimental, investigational, or unproven because the effectiveness of these approaches has not been established. Not an all-inclusive list. They love this little line, not an all-inclusive list. Adhesion removal physical therapy for bowel obstructions, so that might be more pertinent to some of our pelvic floor practitioners. Applied functional science, blood flow restriction therapy, not a covered service. Dynamic movement intervention, not a covered service. Kinesiotaping, McConnell taping, taping in general, not a covered service. Interactive metronome program, not a covered service. Virtual reality facilitated gait training, not a covered service. So there you have it. Just a few highlights, there are a lot more examples in there detailing what a covered versus an uncovered service is. So what's the point that I'm trying to make? The point that I'm trying to make is that, one, there is such a thing as an uncovered physical therapy service. And then if you're a cash pay provider, you are within your rights to charge your patients cash for that service. Where it gets hairy is if you see a patient and something comes up, the intervention that needs to be done is considered a covered service, then you would have to bill Medicare for that. So we have to do our due diligence. We have to read these policy manuals and come up with policies and standard operating procedures to make sure that we're compliant. And for those who are in the insurance-based system, I also want to challenge kind of what they're thinking. I want them to understand what is not considered covered. Most therapists are really just trained to indiscriminately justify everything as a medically covered service, bill it to insurance or Medicare companies, but most of them are flying blind and don't realize that a lot of the services that they're justifying as covered to Medicare, even with the most beautiful documentation, as soon as you look deeper into these policy manuals, you're going to find out actually it's not a covered service and you are at risk for recoupment during an audit. So I'm not going to sugarcoat things. Understanding this stuff is hard. If you'd like to learn more, I definitely suggest checking out Anthony Maritato's Zero to Paid course. Really worth the money. Really gives you a very firm understanding of differentiating between covered and uncovered services, as well as some of the other details like claim submissions, billing, other things that we have to consider. And obviously, it's not fun. It's not fun. Personally, I think it's worth it because, like I mentioned before, people over 65, they're the people who probably need our services the most. And if you're uninvolved with Medicare at all, then you can't really help these people. So from a fulfillment angle, you're missing out on helping the older population. And then thinking about things a little more from the business side, you're also missing out on this huge potential because older adults, they tend to prioritize their health more. They tend to have more spending power, and they also tend to have longer plans of care, typically. But I would say that a Medicare evaluation, the initial session, it's hard to say that that is not a covered service. There are ways that you could do that, pre-screen with a phone call, determine that the physical therapy evaluation for the reason that they're seeking maybe is not covered. But generally speaking, I think the evaluation is probably always going to be covered service. And You have to get paid for that time, but you can't collect it from the patient because of the laws in the country, the mandatory claim submissions, and how we aren't opt-out providers. But any care thereafter is going to differ from case to case. What we're starting to see with these examples I listed is that a lot of the services, a lot of these really good services that a lot of therapists are providing actually aren't covered services, and legally speaking, they should be cash. So there's a lot of opportunity there. And when you do bill cash for these services, there is a paperwork process that you have to be familiar with. Some of you may have heard of it, the Advanced Beneficiary Notice, or the ABN. You're going to find out more about that in CMS Policy Manuals, Chapter 30. So obviously this is a huge topic. We could go on about it for hours. There's a lot of open discussions about it. There are a lot of rules that you have to become familiar with. But my aim with this episode was really to just challenge people's assumptions about Medicare and hopefully help people gain a better understanding of what might be a covered or uncovered service. So for my fellow practitioners out there, I'm always happy to chat on this subject. So if you'd like to shoot me a line, just find me on Instagram at Pang Physical Therapy. PANG, Pang Physical Therapy, and you can just DM me, and I'm happy to provide some resources and chat with you if you have any questions. And thanks again for listening to the Shoulders Up podcast.